Hello, I am Dr. Nesmani, and in this session, number 5 of cardiology, I am going to tell you a few more questions which can be asked in the entrance examination. Please visit my channel www.youtube.com/acepgmet. Also have an account in Facebook and accept my account ACEPGmed as your friend, so that links uploaded will be coming to you every day as and when it is being uploaded. You can use the pause button to freeze the video till you finish the reading and press the play button to resume if you feel video streaming is faster. So please visit my channel youtube.com/acepgmed. The first question of this discussion is mitral stenosis caused by rheumatic heart disease. Prophylaxis against endocarditis is unnecessary in cystoscopy, dental scaling, cesarean section, cardiac catheterization, and transesophageal echocardiography. 5 options are given. Write down which options are true and which options are false. Cystoscopy is a false statement. Dental scaling also is false. The question was unnecessary. So, negative implication is there in the question. Cesarean section, cardiac catheterization, and transesophageal echocardiography are true statements. So, let us now go to the explanation. The American College of Cardiology guidelines recommend antibiotic prophylaxis for dental work, including scaling, cystoscopy, endoscopy, bronchoscopy, and biliary tract disease. It is not recommended for cesarean section, transesophageal echocardiograph, except high risk case, and cardiac catheterization. The key points you have to remember: prophylactic antibiotics based on a patient's lifetime risk for acquiring infected endocarditis are no longer recommended for dental, GI, or GU tract procedures. GI means gastrointestinal, GU means genitourinary tract. This recommendation follows from the observation that most cases of infective endocarditis result from bacteremia caused by routine activities such as chewing food, brushing teeth, and flossing. Moreover, no published data clearly indicate that prophylaxis prevents infective endocarditis from invasive procedures. The dental disease may increase infective endocarditis risk, but emphasis should shift from antibiotic prophylaxis for dental procedures to improved dental care and oral health in patients with conditions that carry the highest risk for infective endocarditis. Simplest procedure is to wash the mouth with the saline after food. Just put less than half teaspoon of salt, common salt, into 1 glass, that is 200 ml of plain water. Mix it well. The taste is that of the tear, and then put it in the mouth for 2 minutes and spit out. That's all needed. Infective endocarditis prophylaxis is reasonable for dental procedures, class 2B of level of confidence C. Hope that you understand what is class 2B and level of evidence. For dental procedures that involve gingival tissues or the periapical region of a tooth, and for procedures that perforate the oral mucosa in patients with the cardiac conditions associated with the highest risk for adverse outcomes from infective endocarditis, like prosthetic cardiac valve, previous infective endocarditis, unrepaired congenital heart disease including palliative, shunt, and conduit, completely repaired congenital heart disease defect with the prosthetic material or device during the first 6 months after the procedure, then repaired congenital heart disease with the residual defect at the site or adjacent to the site of a prosthetic patch or device, then cardiac transplantation recipients who develop cardiac valvulopathy. Then key point number 4 is infective endocarditis prophylaxis is no longer recommended for patients with mitral valve prolapse. Then if administered, antibiotic should be given in a single dose before the procedure. The preferred antibiotic is amoxicillin 2 gram in adult and 50 milligram per kg in children around half an hour before the procedure. The prophylaxis is not strongly recommended for respiratory tract procedures and not recommended at all for bronchoscopy unless incision of the respiratory tract mucosa is necessary. The prophylaxis is not recommended for genitourinary gastrointestinal procedures if there is no invasion involved. Question number 2. Which of the following are true of Wolff-Parkinson-White syndrome? There is an aberrant conduction between atria and the ventricle. Then broad complex tachycardia is more frequent than narrow complex tachycardia. Then verapamil is the treatment of choice for an associated SVT. Then amiodarone increases the refractory period in the accessory path. The atrial fibrillation is a well recognized rhythm disturbance. So indicate which are true and which are false. The false statement is verapamil is the treatment of choice for an associated SVT. All other statements are true. Now let us find out. The hallmark of AV accessory pathway function during sinus rhythm is pre-excitation, in which depolarization of all or part of the ventricle occurs via a pathway that is a separate one from the normal AV conduction system, and that occurs earlier than expected after atrial depolarization. The two main electrocardiographic features of Wolff-Parkinson-White syndrome WPW include a short PR interval of less than 0.12 seconds and a delta wave, which are shown by the red arrows in this picture, which results from rapid ventricular activation via the accessory pathway, while the termination of the ventricular activation is via the normal conduction system, leading to a fairly normal termination portion of the QRS. Nearly full pre-excitation is manifest in normal sinus rhythm on the 12-lead ECG in this patient with a short accessory pathway refractory period. The ventricular complex in pre-excitation is a fusion of the impulse that pre-excites the ventricles due to rapid conduction through an accessory pathway and of the impulse that takes the usual route through the AV node. This fusion creates the delta wave that is characteristic of Wolff-Parkinson-White syndrome. Aberrant conduction occurs through the bundle of Kent, although orthodromic tachycardia is the commonest. It frequently has phasic aberrant conduction, making it broad. Verapamil may exacerbate the rhythm disturbance associated with WPW, and AF may result in ventricular fibrillation. That's why the one option is taken as false. Verapamil may exacerbate the rhythm. In this picture, I am showing you the simplified representation of the various possible accessory conduction pathway in case of WPW syndrome. K stands for the bundle of Kent, J stands for the bundle of James, M stands for the Mahan fibers, and the hatched area represents the atrioventricular border. The AV node, right fascicle, left posterior fascicle, and left anterior fascicle are shown below, and above left you can see the AV node. The right side shows the delta wave in magnification in a single QRS complex. Tachydysrhythmias may require synchronized electrical cardioversion if they are demonstrating severe signs of symptoms like low BP or lethargy with altered mental status. That means the patient is unstable. The BP is normal and the higher function not affected is called a stable patient. If they are relatively stable, pharmacologic treatment is used. Atrial fibrillation and SVT are treated with amiodarone. Adenosine and other AV node blockers should be avoided in atrial fibrillation and atrial flutter with the WPW or history of it. This includes adenosine, diltiazem, verapamil, and other calcium channel blockers and beta blockers. Beta blockers and other pharmacological agents that slow electrical conduction through the AV pathway, such as digoxin, should be avoided because they can exacerbate the syndrome by blocking the heart's normal electrical pathway, therefore favoring transmission through the pre-excitation pathway. People with symptomatic narrow QRS complex tachycardia may be cardioverted. Alternatively, adenosine may be administered. So hope that this session was useful to you. Next session will be uploaded tomorrow. And at any point, if you found that the dictation or audio part of the video is a little faster, I would request you to replay the video, or you can freeze the frame and can read the text, because YouTube doesn't allow more than 15 minutes of video of high quality. Since the quality cannot be compromised, I have done this work with good intention. And please visit the site youtube.com/acpgmatdaily. Already more than 10 videos have been uploaded about practice session of postgraduate entrance test. You can expect more in future. Goodbye.